So after talking about all the hemorrhages, causes of hemorrhages, antepartum, postpartum, and obstetric hemorrhages, now let's talk about another emergency, obstetric emergency, which include uterine inversion and rupture of the uterus. In this section, we will talk about what is uterine inversion, what are the different types of uterine inversion, how we can manage that, and then how the uterus rupture during the pregnancy, and how we can manage if the head is impacted at C-section delivery. So inversion of the uterus or uterine inversion. Uterus is partially or fully inverted. These are the different degrees or types which are explained in these 4 diagrams here. This is first degree uterine inversion. You can see it's still inside the it's not out of the cervix, and it's first degree uterine inversion, not as severe as the second, third, and fourth degree. In this, the inversion is little more than the first degree, then it's coming out, and then it's completely out. So these are the 4 types of uterine inversion. So degrees of inversion: in first degree inversion, the inverted fundus extends to not through the cervix. So here this is the fundus of the uterus is inverted only. In second degree inversion, inverted fundus extend through the cervix. The cervix and this inverted fundus is extending through the cervix here. Third degree, the inverted fundus extends outside the vagina. Now it's extending out of the vagina. And in fourth degree inversion, it's both inverted uterus and the vagina are completely inverted. So these are the 4 degrees of uterine inversion. First degree is not just the fundus is inverted, then second it goes up to the cervix, third it out of this vagina, and in the fourth both the vagina and the uterus are inward. Risk factors for the uterine inversion here is full dilations. If the full dilations occur, then the uterus can become inverted. Malpresentation of the fetus, prolonged second stage. Second stage of the labor is the stage from the dilation of the cervix to the delivery of the baby. If second stage is prolonged, too much pressure in the uterus, on the uterus, and then it can cause inversion of the uterus. Hyperstimulated uterus and IV syntocinon. Syntocinon is given to stimulate the uterine contractions. So if the too much syntocinon or oxytocin is given, then it can cause hyperstimulation of the uterus and cause uterine inversion. So it should be given under very, very strict supervision and should not be overused. These are the pictures of uterine inversion. This is about the third degree outside, and this is the fourth degree when it is completely out. Management of uterine inversions. This is, you can see it's coming out. The manual replacement. Try to manually put the uterus back into the space. So manual replacement. Hydrostatic replacement as a result of the pressure, water pressure, maintaining uterine contractions, and surgeries, hysterectomy should be done, or removal of the uterus can be done also. So these are all the managements of the uterine inversions. Next condition is uterine rupture, when there is complete rupture of the uterus. Common in women having previous C-section. If the women have previous C-section, it can cause uterine rupture if the repair is not strong enough. Signs are maternal shock, fetal distress, no palpations of uterus, and abdominal pain. With the uterine rupture, all these are common. Mother can go into collapse, shock, low blood pressures, and there is distress of the fetus, but no palpation of the uterus when the abdomen is palpated. Management is the laparotomy, opening of the abdomen, and repair of the uterus if there is rupture of the uterus. This was the picture that shows the uterine scar. As a result of previous C-section, there is rupture and the baby comes out of that ruptured uterus. Vaginal examination. Assisted vaginal delivery can be performed. Next is impacted head at C-section. If the head is impacted at the C-section, what should be done? Risk factors include full dilations, malpresentations, prolonged second stage. So they are almost the same as we mentioned in the last slide. So causes full dilations, malpresentation, prolonged second stage, hyperstimulated uterus, and IV syntocinon. Management is full dilation sections, uterus relaxation, uterine relaxant like glyceryl trinitrate or terbutaline can be used. Beware of postpartum hemorrhage. Usually these patients will have postpartum hemorrhage. Senior assistant flex. So this was all about the section 4. Thank you for watching sqadia.com.